Today, we are going to do a quick high-yield review of absence seizures, one of the most important generalized seizure disorders commonly seen in children. Absence seizures are characterized by sudden, brief episodes of impaired consciousness that usually last only a few seconds and then resolve completely without postictal confusion. These episodes are often mistaken for daydreaming or inattentiveness, especially in school-aged children, because the child suddenly stops activity, stares blankly, and then immediately resumes normal behavior as if nothing happened. Understanding the pathogenesis, clinical presentation, diagnosis, treatment, and key exam pearls is extremely important because absence seizures have classic findings that are frequently tested in examinations and commonly encountered in clinical practice. Let us begin with the pathogenesis and mechanism of disease shown in the image. Absence seizures result from abnormal synchronized neuronal firing involving the thalamocortical circuits of the brain. Normally, the cortex and thalamus communicate in a highly organized manner to regulate consciousness, awareness, and sensory processing. In absence seizures, this circuitry becomes hyperexcitable and starts producing synchronized rhythmic discharges. One of the major mechanisms involves abnormal activity of T-type calcium channels within thalamic neurons. These low-threshold calcium channels contribute to rhythmic oscillatory firing patterns. When these pathways become excessively synchronized, generalized spike-end wave discharges are produced throughout the brain. Because the abnormal electrical activity is generalized rather than focal, the seizure affects consciousness diffusely, leading to brief interruption of awareness. Importantly, there is no structural brain lesion in most cases, and many children have otherwise normal neurological development. Now let us move to the clinical presentation, which is one of the most recognizable features of absence seizures. The classic absence episode begins suddenly without warning. A child may be talking, reading, eating, or playing, and then abruptly stop activity and develop a blank stare. The child appears disconnected from the surroundings for a few seconds. During the episode, there may be subtle automatisms such as lip smacking, eyelid fluttering, chewing movements, or small hand movements, especially in more complex absence seizures. The duration is typically very short, usually around 10 to 20 seconds. One of the most important clinical clues is that there is no aura before the seizure and no postictal confusion afterward. Immediately after the episode ends, the child resumes normal activity without realizing anything happened. This feature helps differentiate absence seizures from focal impaired awareness seizures, which often have postictal confusion and longer duration. Another important point is frequency. Absence seizures may occur multiple times per day, sometimes even dozens or hundreds of episodes daily. Because each episode is so brief, parents and teachers may initially interpret them as poor attention or behavioral problems. Academic performance may decline because the child repeatedly loses awareness during teaching sessions. Therefore, school-based recognition becomes extremely important in diagnosis. Teachers are often the first individuals to notice frequent staring spells in affected children. The image next highlights diagnostic criteria and testing, especially the importance of electroencephalography, or EEG. EEG is the primary diagnostic test for absence seizures. The classic and highly tested EEG finding is generalized symmetrical 3 Hz spike-end wave discharges. These spike-end wave complexes occur synchronously across both cerebral hemispheres and are considered the hallmark of absence seizures. One important bedside maneuver during EEG testing is hyperventilation. Asking the child to hyperventilate for several minutes often provokes an absence seizure and triggers the characteristic EEG pattern. This is a classic exam point. Imaging studies such as MRI or CT scans are usually normal because absence seizures are functional electrical disturbances rather than structural lesions. Therefore, EEG becomes the key diagnostic investigation. Now let us discuss treatment strategies, which are also very high yield. The first-line drug for typical childhood absence seizures is ethosuximide. Ethosuximide works primarily by blocking T-type calcium channels in thalamic neurons, directly targeting the pathophysiological mechanism responsible for seizure generation. Because of this mechanism-specific action, ethosuximide is considered highly effective for pure absence seizures and is commonly the drug of choice in children. Another important medication is valproic acid, which is especially useful when absence seizures coexist with other generalized seizure types such as tonic-clonic seizures. Valproic acid has broader antiepileptic coverage and is often selected in mixed seizure disorders. Lamotrigine may also be used as an alternative in selected cases. Choice of therapy depends on age, seizure type, side effect profile, and associated neurological conditions. One of the most important high-yield warnings highlighted in the image is avoidance of certain antiepileptic drugs. Drugs such as carbamazepine and phenytoin can actually worsen absence seizures rather than improve them. This is an extremely important examination point because these medications are commonly used for focal seizures but are contraindicated in typical absence epilepsy. Therefore, recognizing seizure type correctly before initiating therapy is crucial. The image also emphasizes management of symptoms and lifestyle considerations. Since absence seizures involve sudden brief interruptions of awareness, safety precautions are important during activities such as swimming, cycling, or operating dangerous machinery. Even though episodes are short, accidents may occur if awareness is lost during high-risk activities. Families, teachers, and caregivers should be educated about recognizing seizure episodes and ensuring medication adherence. Consistent medication timing is important because missed doses may increase seizure frequency. Certain triggers such as fatigue, stress, sleep deprivation, and flashing lights may worsen seizure activity in susceptible individuals, so avoidance of known triggers is encouraged. Another important aspect of management is psychosocial support. Children with frequent absence seizures may struggle academically or socially if episodes are not recognized early. School-based support and awareness can significantly improve educational outcomes. Fortunately, many children with typical childhood absence epilepsy have otherwise normal cognitive development and excellent long-term prognosis when treated appropriately. Now let us focus on some important high-yield reminders and complications shown in the image. One key differential diagnosis is focal impaired awareness seizure, previously called complex partial seizure. Absence seizures are usually very brief, generalized, and followed by immediate recovery without confusion. In contrast, focal impaired awareness seizures are typically longer, may begin with an aura, and often have postictal confusion or fatigue. Differentiating these conditions is clinically important because treatment approaches differ significantly. The prognosis for childhood absence epilepsy is generally very favorable. Many children outgrow the condition by adolescence or adulthood, especially when seizures are well controlled with treatment. Mortality is low and usually related indirectly to accidents occurring during seizure episodes rather than the seizures themselves. Most patients achieve excellent seizure control with appropriate medication and continue to lead normal lives with good neurological outcomes. To summarize this quick review, absence seizures are generalized non-convulsive seizures caused by abnormal synchronized firing within thalamocortical circuits involving T-type calcium channels. Clinically, they present with sudden brief staring spells, interruption of consciousness, absence of aura, and immediate recovery without postictal confusion. EEG shows the classic generalized 3 Hz spike and wave pattern, often triggered by hyperventilation. Ethosuximide is the first-line treatment, while valproic acid and lamotrigine are important alternatives. Carbamazepine and phenytoin should generally be avoided because they may worsen absence seizures. Early recognition, proper diagnosis, consistent medication use, and supportive education allow most children with absence seizures to achieve excellent long-term outcomes and normal daily functioning.